May I call upon Dr. Shivani Patnaik? Dr. Shivani will be talking on periocular necrotizing fasciitis, a review of 3 cases.
Good morning, everyone. Good morning, judges and audience. My topic is necrotizing fasciitis. This is a 55-year-old, next please. This is a 55-year-old healthy female who presented to the hospital with pain and progressive tense swelling of the right side of the face since 5 days. There was associated tenderness. There was a positive history of an insect bite, no history of systemic illnesses, and the patient was taking oral amoxiclav for a period of 5 days, but no relief. This was a photograph taken by the patient on the cell phone prior to presentation. So she actually presented like this, where there was a black quadrangular essure on the right side of the face, which was measuring as mentioned, and there was cellulitis extending under the essure around 1 to 2 centimeters around it in the upper maxillary area, which was tense, and a diagnosis based on this of necrotizing fasciitis was made. So we assumed that the skin, subcutaneous fat, and few muscle fibers were involved. We couldn't image because the patient was financially constrained. So we planned to debride as an emergency. We stepped up the patient to 500 milligrams of intravenous vancomycin and amikacin for 5 days, and routine investigations revealed leukocytosis and an elevated C-reactive protein titers. Patient was posted for emergency debridement. So after debriding the tissue, and there were few pus pockets which were relieved, and daily dressing was done. On day 15, we had generalized healthy pink granulation tissue with sloping edges which were seen across the whole area. Significant reduction of the defect size had occurred, but not complete, and it would have led to deformities. So we decided to go for an autologous retroauricular full thickness skin graft. So with the graft in situ, it was allowed to heal, and the sutures were taken out. After the suture removal, this was 1 month after the skin grafting, and pigmentation was starting to begin. This was the picture 6 months after the grafting, and it had successfully accepted. There was evened out cutaneous pigmentation over the graft, and no functional or structural deformity seen, and acceptable cosmesis. So this is necrotizing fasciitis is described as an uncommon, and mostly in immunocompromised patients, where it really steps up and picks up very fast and spreads rapidly. My patient was not immunocompromised otherwise, and no systemic illnesses. And it is in this presented case, there was a swift progression from cellulitis to necrotizing fasciitis in a short span of 5 days. And we should have a high suspicion for any case presenting like this. And an autologous skin graft was given to avoid cicatricial complications and ensure adequate cosmesis. So the take-home message from this is that early detection and aggressive management is our motto, and a high index of suspicion and early broad-spectrum antibiotic cover is the cornerstone for management. Surgical debridement remains the primary treatment principle, and skin grafting aids in preventing cicatricial deformities, maintains facial contour and the cosmesis. These are my references. This is the course of the patient. Thank you.
Dr. Shivani, the title says review
Yes,
of 3
actually
cases.
there was a mistake there.
Could you have allowed the debrided area to heal and then secondarily graft rather than doing while the infection was still recovering?
We observed for daily for a period of 15 to 20 days. Then we saw that there were sloping edges, healing. It was looking like a healing wound, and healthy granulation tissue had started appearing. And that's why before there was any cicatricial complication, we decided to go ahead with the grafting, sir.
Any questions from the audience? There's nothing, I think. Thank you very much.
Thank you, sir.